Okay. Okay, for those of you that are on a computer, can you see the triage, the EMS triage, pandemic triage protocol?
Mm-hmm.
Okay.
Yeah.
Okay, so I guess we'll get started. Good evening, everyone. So Dr. Wasserman and Dr. Raybridge are also on the line. And I wanted to have this meeting tonight for a couple of reasons. The main reason is that a lot of information has come out to us over the last couple of days, and it's clouding our decision-making, you know, on a lot of patients. And I'll give you an example of what happened. Yesterday, we had a call where we had a 70-something-year-old man who called us for respiratory distress. And, you know, unknown if he was COVID positive or not, I guess, but there was a question of whether or not he was COVID positive or not. But the long and short is that there was a decision that he did not need to go to the hospital on the part of the paramedics. And I'm not sure if BLS consented. The patient subsequently was not taken to the hospital. We did not complete an RMA where we got a patient signature on it. About 2 or 3 hours later, we were called back to the house and the patient was in cardiac arrest. And we told the family there's nothing we could do, and we pronounced the patient. Medical control was not contacted on the RMA, and it was not contacted on the field termination. The family subsequently has contacted the Voluntary Ambulance Corps requesting information, and they had the cardiology office contact us requesting information as to, you know, why this was not done. And, you know, if we look at this form here, right off the bat, the patient was 70-something years old. And one of the things is, you know, a patient over 65 would be a situation where, you know, we kind of have to consider transport. So I know it's very tough. I know it's very difficult. I'm not pointing fingers. I'm not, you know, saying anything, but I just thought having the medical directors on the line to discuss it with us and for you to be able to ask questions would be helpful. So I will turn it over to Dr. Raybridge and Dr. Wasserman to, you know, discuss their feelings on these different documents that came out.
Can somebody mute that?
Yes, I will.
Okay, Frank, can you just, or if anyone is not speaking, if you can mute, there's a lot of background noise.
Okay, so I'm going to mute everyone, and then Jeff and Dr. Wasserman, if you guys could unmute yourselves, okay? And then once you finish talking, you know, whoever else wants to ask questions should just unmute themselves. Okay? Okay, so.
Great, thanks.
Okay.
You can hear me?
I can hear you, yep.
All right,
Can you hear me?
Yes, I can hear you, Dr. Wasserman.
yes.
Okay, good.
So the first thing we wanted to talk about is the viral pandemic triage protocol that Frank has up there. This can be used by ALS or BLS. It's not specific to level of care, but it's a little confusing to follow. So we wanted to go through it. You know, basically this was designed for the patients that have very mild symptoms that we all know don't need to go to the hospital. You know who these people are. These are the young, healthy people who basically, you know, are worried they have COVID or they don't feel well or they have a sniffles or a little low-grade fever and they want you to take them to the hospital. So this was designed so that you could not transport them and then leave them the information sheet, which we'll talk about in a little bit, to go through there. But what's happened, and it's not specific with RPS, I'm seeing it with the BLS agencies as well, is that a lot of agencies have used this as a license to say, hey, you know, your complaint doesn't seem that serious. We're not taking you to the hospital. And you really can't treat it that way. There's very specific inclusion and exclusion criteria. So basically, you know, they have flu-like symptoms, you know, fever, sore throat, cough, congestion. And then there's a whole list of exclusions, right? So then you have to go through and, you know, one of the problems with yesterday's call is right away, they have to be under 65 years of age, right? So what we're seeing is that, you know, a lot of these people who get sick are in their 70s, 80s. They may have comorbidities like high blood pressure or diabetes, and all those things are exclusions. So you have to really follow this closely. But if you do get to the bottom of it and the patient meets all the criteria, then you can not transport them and leave them the information sheet that the state provided as well. And I assume that, you know, all the stations have copies of this. I think it was printed out and you have copies.
Yeah, I put 75 copies in every station.
Great. And then you'll see on that bottom, so you think they don't need to go to the hospital and the patient agrees, that's great, you're done. If you think they don't need to go to the hospital, but the patient still insists that they want to be taken to the hospital, that's where you call medical control to get advice, right? So you feel they meet the criteria, one provider puts on PPE, right? Want to conserve the PPE. So one provider will put on PPE and then get close enough to do the assessment. So again, if they have, if they're over 65, if they have high temperature, they have abnormal vitals that you can see there, then, then you go over to the side where it says, yes, follow standard BLS and ALS treatment protocols, right? Any difficulty or unclear situation, consult medical control. If not, and they don't have any of the comorbidities, then you can not transport. And then if there's any confusion, or the patient, you think this patient's uncomfortable with this, or you're concerned, then call medical control. We can also, just like we do with a regular RMA, you can put the patient on the phone with us, and we can explain to them, basically that nothing's going to happen if they come to the hospital. They're not that sick, and that we can't test them, or whatever they think is going to happen at the hospital. We can explain, what actually would happen, and that may be enough to convince them not to go. So I just want to do this one first and see if there's questions on this before we move on to the field termination, because they're two separate things, but they came out kind of in close proximity, and I think there's confusion about it. So I don't know if Adrian wants to add anything to that, or.
Yeah, I did want to add a couple of things. So number one, I encourage you guys to please call medical control if there's any question about the patient's symptoms, whether or not the patient wants to go. If you get an uneasy feeling, because we're doing something very similar where patients that arrive by car, we're triaging them it's the same way as you're triaging them at their homes, essentially. And I have, of course, a PA or an NP outside, but I tell them the same thing, is that if there's just something about the way the patient looks, whatever your gut feeling about this patient is, if you don't feel like they're safe to stay home, you should, even with this, hard and fast criteria, if there's something about them that doesn't look right, you should err on the side of caution and let a physician or a PA or someone evaluate them in the hospital. The other thing I wanted to kind of make clear is you guys should be careful if you are going to call medical control and then hand the patient the phone, whether that's their phone or your phone. I would recommend you put your phone in a plastic bag. You don't want to be bringing that phone back to your face if they've talked on it or even touched it. You can use speakerphone, of course, but even on speakerphone, people tend to bring the phone close to their mouth when they speak. So I would use your phone like a PPE, put PPE on your phone, put a Ziploc bag on your phone. After the patient touches it, discard the Ziploc bag, use alcohol on your phone, and put it into a new Ziploc bag. So that's what I had to say. Did anyone have any questions, either what Jeff said or what I said?
If you have questions, you have to unmute yourself.
There's also, if you're on your computer, there's also a chat feature where you can questions that way.
I have a question on that. Hello?
Yeah, go ahead.
Go ahead.
So this is Rob Sobel. My question is, with the RMA thing, is anybody doing anything about getting that done in Spanish?
I sent an email to the state, I guess, I don't know, whenever it first came out. You're talking about the triage one, or the ones this week?
The information form you're talking about?
The information form, and because I've had that were Spanish speaking only, not this week, but a couple of weeks ago. So
when it first came out,
it is an issue.
When it first came out, I forgot who it was, but somebody emailed me within like 10 seconds of it going out. So I sent it out onto the state, and I got a reply of, great idea. So that's been the extent of it so far.
You can translate these forms yourself if you have someone, someone in-house that you trust with the translation.
Out of your fucking...
Hey, sorry, this is Shay. I have the ability to do that. I was a translator for the Army. I can do that for you.
Okay, great. Thank you.
Hey, Frank, do you have access to some kind of translator line like we use in the hospital? We use like a
Yes.
call-in number where
Yes, CP and Bert have it. I could send it out. I just have to get the information, but I could send it out to everyone.
I mean, that may be helpful in getting, even if calling medical control, if you had the translator on the line, that may be helpful to
Okay.
speak to the patients.
I'll work on that tomorrow. Yeah, who's ever making dinner, can you,
Yeah, everybody's making dinner off mute. Other questions? Are people using this protocol?
well, judging from the amount of canceled, I would think that people are using them and canceled
So
in
that-
RMAs and stuff.
So that's a good point. I just want to reiterate. So if you go to the scene, you evaluate the patient, and you use this protocol, and you leave them on the scene, that is not a canceled job. So I would caution you all that you should be writing an appropriate PCR for that, because if a situation happens like, the patient, and we're seeing some of these patients, who look fine, and the next day they crash, and some of them are dying. You don't want to be in a situation where you were on the scene the day before or hours before, and there's no documentation of that job. So, it doesn't alleviate you from the responsibility of writing a PCR just because you're using this protocol and not transporting them.
I agree. Is there anything that the field providers would like to know about what we are telling patients in the hospital when they come in and we're discharging them? I know probably a lot of patients are asking about testing or about chest. I want a chest X-ray. Is this something that you guys are seeing? Like, oh, I just want to go to the hospital and get a chest X-ray. Is there something that we could tell you about our processes that
Or questions about testing for COVID? I mean, we can talk about that. Who we're testing, who we're not.
That would be helpful, because there's a lot of patients who want to go just for testing.
Right.
Sure.
So, I know Adrian and I speak often, and I think we're doing the same thing at both sites, but we're not testing, the general population. So people will come in, they feel a little sick, and they want to test. The labs, as you can imagine, are inundated with these tests. So both the number of swabs to collect the test, the viral transport medium, the reagent to run the test, and then the human bandwidth to run all these tests is limited. So, the position right now is that we're only testing patients that are sick enough to be admitted to the hospital, because it helps us know who we can cohort in rooms together, and as far as treatment for patients who get sicker. But, the well-appearing person who comes in and says, I don't feel good, I want to test, we are not testing those. The other thing is that the current test we're using is only about 75% sensitive. So, if you have the symptoms, COVID is around everywhere now. If you have the symptoms and the test comes back negative, you probably still have it. So, there's very little value in testing well-appearing people. So that's kind of what we're doing with testing right now.
Yeah. We're doing the same thing. In addition to that, we get a lot of patients that come in and they want a chest X-ray. Either their primary doctor told them, oh, you need a chest X-ray, or they decided themselves that they need a chest X-ray. The chest X-ray does not change the management in any way. We've sent people home with bilateral pneumonias who are saturating it within decent limits, and they go home. So we've actually stopped chest X-raying people as well, unless they're getting, admitted. Every time we chest X-ray someone, that means we have to put more PPE on the X-ray tech. It exposes more people to the possibility of getting the virus. So we're trying to limit those unnecessary chest X-rays. So, if a patient appears well, if their oxygen saturation is above 90%, we typically are not chest X-raying those people unless we have another reason to admit them or we're looking for something else. But that we're seeing a lot of that in our drive-up triage and release. People wanting chest X-rays, people wanting antibiotics. They read, oh, I read that I should get Zithromax. We're not really prescribing Zithromax for most people. In fact, good luck getting it out of pharmacy now. I don't think. I mean, it's pretty much, I would think, out. So we're really, and the other thing that we're stressing to people in our drive up, treat and release patients is, well, there are two types of patients, and we never want to downplay a patient's symptoms. I'm sure they feel miserable. However, the types of patients that we're seeing patients that are miserable but don't have any life-threatening symptoms, and the patients that are miserable and have life-threatening symptoms. And so we're most we're treating the people that have life-threatening symptoms. The ones that are miserable but can get by, yeah, they might be a little short of breath, or they have a fever, or they have aches, or they have a really bad cough that's keeping them up at night. Those are all annoying symptoms, but those are not life-threatening symptoms. And sometimes the patients just need to hear that your symptoms are just you calling EMS or you calling the doctor or whatever. It's justified, but you're not in a life-threatening condition right now where you need to be evaluated.
Right. We're seeing, it's very interesting. We're seeing the same thing, especially with the urgent cares and doctor's offices too, where they want to send someone in for a chest x-ray. And, you know, chest x-ray and CT, those things really, we have found are really of no value in managing this disease or treating it. It's really clinical. It's really based on, you know, what's their saturation, what's their respiratory rate, you know, are they in respiratory failure or not? Do we need to treat them? Every one of these people, if you get a chest x-ray, the x-ray looks terrible. Even the ones who are walking around who look good, you know, who have SATs 96, you do an x-ray, they have an infiltrate. So, you know, it's not like the x-ray is going to really help us manage these patients.
Yeah.
Anything else about this or what we're doing that you have questions about or is confusing or?
I wanted to bring up one other thing. I know we're going to be talking about codes and terminations and all of that. There are a lot of rumors, I think, in the EMS community. And I think that's one of the things Jeff and I wanted to address in talking to you tonight. Every hospital is short on vents. And there's no way that we can give any EMS, we can't even give our own staff the numbers of vents we have, because it changes so rapidly. I mean, in the ER, we can intubate 3 people in 1 hour, and our vents go down. We had 6 available vents, and now we have 3. But at the same time, there could be 3 deaths in the ICU, and now we're back up to 6 again. So again, there's no way that we can like give an hour by hour or minute by minute count of what the availability of vents are. And I think that gives a lot of people, EMS providers in the community, a little bit of anxiety about, are we going to be able to treat this patient if we bring them to this hospital or that hospital? So calling and asking the charge nurse doesn't help, because the charge nurse doesn't know. I can tell you that we have vents, you know, in a last resort, and the same probably goes for NIAC. In a last resort, we have anesthesia vents that we use in the operating room. And so, you know, we'll know things are bad when we're already on our anesthesia vents, because those are like a last resort kind of thing.
Yeah.
Jeff?
And there's things we can do, like we're using some of our BiPAP units that can be used as pressure support vents for people who don't need as much ventilation. We have a plan for splitting vents where we can ventilate 2 patients off 1 ventilator. So there's lots of things we can do if we have to do. But like Adrian said, it changes by the hour. We could have 3 intubations, but then, you know, 3 codes an hour later. So, you know, there's certain agencies that call and wanting to know what's our vent count. And it's just impossible for us to keep it updated. All right, Frank, should we move on to the cardiac arrest, or are there other questions?
Sure. Let's see.
Actually, I have a quick question, if that's all right, Frank.
Sure.
So are we communicating, or the hospitals communicating with the area facilities? Because it seems anecdotally that we're getting calls to some of the licensed facilities in the county where the nursing staff is asking us to transport patients to the hospital for evaluation, specifically to get COVID tested. And the crews are reporting that they're arriving to find what they believe to be stable patients. Bo and I had an experience over the weekend where we went as bosses to evaluate a scenario where the facility was sending 3 patients out. And when we arrived, based on our evaluation, the patients were extremely stable and didn't necessarily need to go out. The nursing staff had already called one hospital, and they were told that they weren't going to accept them, that the patients didn't need to come based on their description. But the facility physician was requesting that the patients be transported anyway.
Yeah, so to answer that question, and I can speak for NIAC, and I'm sure Adrian's doing something similar, but our case management and our physician leadership at the hospital has spoken to every SNF in the county, every agency we deal with, the urgent cares, all the doctors on staff, and they've been given all the same instructions about not sending these patients in. We have received calls from, we've even told the nursing homes that they basically, like you're transferring interfacility, they have to call us and we have to accept the transfer before they come in. Again, some of the doctors in the community and these nursing homes they're just either oblivious to it or not playing along, or they keep saying they want the patient sent in. And what we've emphasized to them too is that, and this is a situation where the governor actually helped by basically he told these nursing homes they're obligated. If they don't take them back, because we've had them come in and they say we want them tested because they can't be, if they're here, they can't be here if they're positive. And the governor has made it very clear to them that they will take those patients back and isolate them there, and that they will face significant fines and prosecution if they don't. So that part of it they've been good about. So we've told them, look, there's no point in sending them in to test them if they're well appearing, just isolate them. But as you know, not all facilities are the same. Some of them are a problem. We're getting people from like Muncie Park and Green Hills because they want them evaluated by psych because they refuse to leave their mask on or they refuse to stay in their room. So again, not really a psychiatric issue. That's an administrative issue for the facility. But unfortunately, these things are happening. And I've heard from other medics as well that are we talking to the doctor's offices because they keep calling it? Yes, we are talking to the doctor's offices, right. But as you know, it's some people don't listen.
Understood. Thank you.
Yeah, we're seeing the exact same thing. I got into it with some kind of, I don't know, a group home of sorts where there was one person who was positive there, and he was a behavioral issue. He didn't want to wear his mask, and the completely untrained attendant at this place just he must be sick because he's not acting like himself and he keeps pulling off a mask and he's going to infect everyone else. And I said, you can send the patient over, but we're sending the patient back. I can't tell them not to. I can advise them, don't send them, but I can't absolutely refuse them from showing up. They could show up, we'll send them back, and they have to take them back. And I think a lot of the problems are with the community physicians that rotate through these nursing homes. Some of them are just not on board. Either they don't get it or they don't want to deal with it. Or
they don't want to evaluate the patient themselves, right? They're not at the nursing home.
Right. Or the nurse will call up the doctor who doesn't come in except once a month, and they'll say, this person has a cough and we're afraid and we need this patient tested. And then all of a sudden it's, an emergency. And that's difficult to control.
Can we talk about the,
I was just going to clear up something with the vents, because there's some comments on the chat, is that, no, I don't think any medic has ever said there's no vents available, but there are, everyone's worried about running out of vents. So there's a lot of talk out there, and of course there's miscommunication, and, someone may bring in a patient that gets tubed and hear a respiratory therapist or someone comment that, oh, we only have a few vents left or whatever. And, it's like a game of telephone, you know how that goes, but we are not out of vents. I don't believe either hospital is out of vents. So, it's definitely not coming from EMS, but, misinformation is getting passed along by various people.
Jeff, can we just talk about the vents from the nursing homes for the RMC crews?
Yeah. So for the RMC crews, right. So because everyone is so concerned about vents, again, the governor in his, demands of the nursing home also said, look, if you have a chronically vented patient at a nursing home that's on a vent all the time and you're going to send them to the hospital, you have to send them with their vent. They have a vent. It's their vent from the nursing home. They have to come with their vent, so we're not taking up another vent at the hospital for that patient who's chronically vented. So I know when we reconfirmed this week that both Friedwald and Northern Manor, who are the ones we deal with mostly at NIAC, the administrators there both reconfirmed that, yes, they understand that, and they will send the vent with the patient. So, if RMC, if you're doing a transport from an event-dependent nursing home patient to the hospital, that vent has to go with you to the hospital. And if there's a problem with the administrator in the nursing home, if that happens,
call me.
Then call your supervisor. Yes.
Yeah, I have their phone numbers now, so I've been in contact with them, and they're calling me every time there's an issue. So I have their phone numbers. You can just call me. My phone's on now 7 days a week, 24 hours a day, so you can call me. The only one I asked, yes, just one thing. Helen Hayes. Did anybody follow up with Helen Hayes as far as?
Yeah, we did. We talked to Marjorie King, and Leon Harris talked to Marjorie King as well. I just wanted to address, Jason asked a question about wearing a mask as a general precaution. So in my opinion, this is just my opinion, Jeff, I don't know how you feel. All of us in healthcare that are seeing these patients on the front line, that includes EMS, that includes everyone that works in the ER, all of us are at risk. There are patients out there that are asymptomatic or that have very minimal symptoms. And so I made it a rule in my department that everyone wears a mask while on duty, a surgical mask while on duty. And the reason for that is, number one, not only protect yourself from the patients, but also to protect each other. Just like my docs are sitting next to each other, documenting, sharing the same phones, the EMS crews are sitting in the same cabs of the car or the ambulances all day long. You guys are in close quarters. You're sharing the same breathing space. You're probably eating together while you're on duty. And this virus is very contagious. So in my opinion, listen, if you go and your partner is asymptomatic but contagious, and then you get it, and then you pass it to another person, then you could have 3 paramedics or 3 EMTs out for 2 weeks or more, or worse. They could be really sick. So in my opinion, I think you should wear a mask while on duty at all times. And for all calls, even for a sprained ankle or something. You know what? You don't know. You just don't know. It's so prevalent in the community.
Everybody has COVID, right? We had someone the other day with a finger laceration, right? They had a syncopal episode. They fell, they cut their finger. Well, why'd they have a syncopal episode? They had 103 fever while they were in the ER, and you know what? They had COVID. So everyone has it. I agree. Our staff are wearing masks their entire shift. As far as the other part of your question, like if you're going to the grocery store, the CDC is actually weighing that option now. They're not sure. They're considering saying everyone should just wear a surgical mask when they go out of the house. But they're also concerned that would create a shortage of surgical masks. So they haven't really come out with an opinion on that yet. I see people doing that. I don't know how helpful that is. But certainly when you're in close proximity to people, like when you're at work and so forth, I would wear a mask. All right, so we're gonna just go over this cardiac arrest protocol. So the first thing I want to say is that you're all familiar with the termination of cardiac arrest protocol that has always existed in the collaborative protocol, right?
Do you want me to put that up?
Sure.
Okay, give me a
have
second.
it.
I do have it somewhere. Hold on. Well, keep on talking on this one.
Yeah.
Oh, here it is. Here it is. I found it. Okay.
Right. So termination. So this you should all be familiar with. It already exists. It hasn't changed, right? So patients who do not meet the extremis obvious death protocol but are in arrest, right? They meet all the following. So they're adults, not witnessed by bystander or EMS, no bystander CPR, no AED shock advised, and no ROSC, right? And 20 minutes of resuscitation. This actually is a validated termination rule that comes from the American Heart Association that was based on the Ottawa protocols, and you can terminate the arrest, right? So that's always existed, so that's nothing new. What we put out this week, which actually originally came from the Albany, from the Remo region, but now most regions have adopted it, is that if you're working a medical cardiac arrest, right, or blunt trauma for that matter, and you do not achieve ROSC, the patient should not be transported to the hospital. While we put this out now as part of this pandemic response, this is not a new idea. This was actually, many parts of the country have been doing this since 2009 when this data came out, 2009, 2010, where, if you don't, you do the same ACLS we do. If you don't get a pulse back after 20 minutes of CPR or of ACLS, we're not going to get a pulse back. So to transport them in a moving ambulance, whether it's mechanical or manual CPR, and have the crew back there, and now especially with COVID, with a BVM and all these aerosol generating procedures, there's no value to the risk. Far outweighs any benefit. So the way it reads now, Frank, if you want to go back to that other one.
Which one do you want?
The new from the region, the
Okay.
advisory. What that says now is that there's no medical benefit, right? Like I just said, to transporting them with CPR in progress, and given the lack of evidence supporting transport, the new procedure is no adult medical cardiac arrest is to be moved to a hospital with manual or mechanical compressions in progress without either ROSC or a direct order from a medical control physician unless there's imminent danger to the crew, right? So we have to put that in there. If you're in a place where, you know, there's about to be a riot if you don't transport this person, you know, because you're in the middle of the street somewhere and the bystander crowd is going to assault you if you don't do it, then obviously you have to do what you have to do to protect yourself. But barring that, we should not be transporting cardiac arrest. And I can tell you that the cardiac arrest we've been getting, the minute you guys arrive at the hospital, we've been terminating. I don't know, some of you may have seen that. We've been just pronouncing as soon as you get there.
Same here. Same on this side. Yep.
So questions about this one?
Yeah, so then why are we doing this in the field?
Doing what in the field?
If you're terminating a COVID-19 as soon as we get there, you're putting us at risk for doing this in the field for how long? Half an hour, 45 minutes?
You know, you shouldn't be doing it for more than 20 minutes.
20 minutes.
But no,
Number one.
now we're doing this and we're transporting because we have a imminent physical danger because the family is ready to shoot us and there's no cops on the scene.
Okay, that's a separate issue.
There's no police department no, it's not. It's the same issue. There's no police on the scene, and we're trying to like tell these people, and we're.
So you're telling me that the police are not responding to a cardiac arrest?
Nope. My partner yesterday had to call and get them to come in after the family had freaked out. You know what I'm saying? It's a tough situation.
I hear what you're saying, but there's no medical value to transporting a cardiac arrest. So that's why we're not transporting.
We agree with that. I am 100% on that. But
So
why are we doing 20 minutes of resuscitation on a positive COVID person with no BLS? And then we're going to tell the family we ain't taking them anywhere.
So would it be helpful for you to say, we've been coding your family member for 10 minutes, whatever. We don't have a pulse at all. Our protocol is to call the medical control physician and find out if there's anything more that we could do before we to stop.
Listen,
would that help?
Dr. Wasserman, there's no easy answer to this because I'm just trying to tell you what we're doing in the field is tough. And these families are not going to listen to anything like that. The only thing that they listened to yesterday was, listen, your father, your husband, he died here at home. If you went to the hospital, you wouldn't have seen him ever again. That's the only thing they listened to yesterday.
Look, look, pronouncing a code, and you know, now you guys are you're not transporting. It's the same thing that we do in the hospital. There's tough conversations you have to have with the family, right? But
not
like
the
you
tough
said,
conversations, but you have people there to help you out. It's me and my partner and an EMT most of the time.
I hear what you're saying. That's an operational issue that we could address separately. But
okay,
we're not transporting codes to the
I'll let it
hospital.
go. I'm sorry. I'll let it go.
Well, I mean, you could always, like you did, request a PD to respond to the scene. So if it's a cardiac arrest and you want to request them right off the bat to have an officer respond to the scene, I'm sure they would respond.
They did, but they did not come in. They won't come within 200 feet of the house.
Then retreat. You know, I mean, if it's dangerous to you being there, then you should retreat. You know, I mean, there's nothing else you could do
until the police arrive. And you know, that's something that, Frank, we could follow up with the individual police departments. But my understanding and talking to multiple police departments in the county is that they would respond to a cardiac arrest, and that if EMS needs assistance, they would go in.
Problem is it's coming in as a difficulty breathing with flu-like symptoms, and they are not responding on those calls. And then we get there, and it's an arrest.
Right, but there are many jurisdictions in the state, I mean, outside of Rockland County, where police don't respond on medical calls routinely, and you have to call them when you need assistance, just like you did this time. What else?
I'm good.
Frank, I have a question.
Sure.
Now, so the only thing for RMC crews should be that they're bringing in, like, vent related, should just be the vent bag that includes, like, you know, the spare tubing and everything.
Yeah, because I think if we bring in our vents, they're not going to want to give us their vents. I'll be honest with you. Mm-hmm. So that was the pushback. You know, that they're very concerned that their vents are going to get misplaced in the hospital. I mean, they wanted
we've reassured them that their vents would be labeled. They've all just, you know, we've told them to label their vents now. And we told them we track them. You know, we have a tracking sheet for that stuff.
Right. Yeah. I mean, they wanted us to sign some kind of, you know, that we're going to agree to take responsibility of their vent and stuff like that. I told them we couldn't do that.
I mean, if it's okay with you guys, shouldn't we just not bring anything in except for the monitor on these jobs? If we bring our vent bag in, we don't need to change tubing. We're going to be using their whole setup.
All I said was any ancillary equipment you think you need, you should bring in. If you don't think you need any ancillary equipment, then by all means, don't bring anything in.
Hey guys, this is Paul. Can you hear me okay?
Yeah.
Yeah.
Okay, so I had a vent patient the other day out of Northern Manor, and they were really agreeing to give us their vent. They said they have a number on it and everything. It actually went really well, except for their vent, even though it's the same as ours, it's not exactly compatible because ours has a special tubing to connect to our portable oxygen tanks. So what we did was bring in our vent, used our equipment to transport the patient, but brought their vent with us. And then when we got to the hospital, connected their stuff up to the main line at the hospital, and transferred them over to their vent while they were in the hospital. Just giving you a heads up, that's all.
Okay.
Thank you. Does anyone have any other questions?
Yep. It could be on anything. We just wanted
anything.
to cover those two protocols, but whatever else while we're here, anything else you guys have?
Okay, I mean, if everyone thought this was useful, you know, I spoke with Jeff today, and I'm sure Dr. Wasserman is fine also. We could try to do this on a weekly basis, even if it's not just controversial stuff. You know, we could try to start doing some medical control, CME, maybe, you know, hour block at a time. So I'll ask everybody tomorrow, you know, if you guys thought it was useful, then we could, you know, do something like that.
It's a good idea.
Absolutely.
Okay. So if everyone's done, thank you.
Hey, Frank.
Yes.
Just one thing with what Dave was talking about.
Like the glasses.
Thank you. With the PD, Ray is going to reach out to the different police departments to make sure that doesn't happen again. Yesterday.
Yeah, I think the point that was made is valid, that if the job comes in as a difficulty breathing with fever or something like that, they don't realize it's a cardiac arrest, they're not going to respond. But, you know, we need to make sure that they're on board with, you know, if one of our medics says, look, I need the cops here, they got to be there, and they got to be there right away.
Yeah, but the thing of it is, like with that, they can listen. I'm going to be honest. They're sitting. They're not doing much else. They can be on the block if they don't want to come in. So if there is an issue, even on something normal, that they're in the area, not that now they got to come from a longer distance away. Trust me, we know they're not. They're doing very little out there, and I get it. But they can be in the area. You know, we should make sure that they're there.
And I know that their departments, they've all been issued N95s and stuff, so there's no reason they shouldn't be able to come in and help.
I have a couple of questions.
Yeah, Rob Sobel has a question.
Go ahead, Rob.
Okay, so my first question is that one of the things that we're seeing are some of these patients who they're definitely sick. Their SaO2 may be in the 80s, but as soon as you put them on oxygen, they come right back up to normal. Obviously, under normal circumstances, that would be an ALS call. If they're just going to be put on oxygen and brought in, is that something that we need to go in on?
So my personal opinion on that is no. Like if they need a non-rebreather of 15 liters a minute, yes, you should go in, because the next thing that's going to happen is they're going to end up crashing and getting injured. But if they're in the 80s and you put them on a cannula 2 to 4 liters and their sats come up to the mid 90s, I think you're okay with that. It's just like in the hospital, if someone was getting that amount of oxygen, I'd put them on a regular floor. But if they're on a high flow non-rebreather, they're getting like at least intermediate care or the ICU. So same idea. I think if just a little bit of oxygen makes them good, then I think that is probably a safe BLS call. I don't know how Adrian feels about that.
Oh, I would say, I mean, I agree with what you're saying. Caveat that as more and more calls go out, the paramedics may be stretched very thin, and they may not be able to respond to all of those calls. So if you get to the point where there's not a paramedic available in a timely fashion because they're on other calls, maybe that person that you do put on the non-rebreather and they do stabilize with that, potentially could be brought in.
Okay, because I had one yesterday, and it's usually a BLS person that I trust without question. And as I was donning my PPE, he said the guy's SaO2 was 54.
Yeah.
And I was like, wow, put him on a non-rebreather, I'll be right there. And I got into my gown and whatnot, went in there, and with him on like 10 liters non-rebreather, he came right up to 97%. So I don't know if that was an erroneous first look or what the deal was there.
So
it could be erroneous, but we're seeing a lot of patients that come in with horrible looking. I mean, they're cyanotic and they look horrible, and you put a mask on them and they're right up.
Yeah. What we're seeing is that this virus, it attacks hemoglobin as well. Almost like when you get like a methemoglobinemia, they're seeing that, what they're calling the happy hypoxics. Like people are in the low 80s or even like high 70s, and looking at them, you wouldn't know it. And then you have put them on oxygen and they improve, but they're not like a SAT 82 and look like they're about to die necessarily. So we're seeing SATs all over the place.
Okay. My other question was on could you guys give me your best recommendation on when we should intubate these people in the field?
I'll tell you that that is the $10,000 question, because we are having that same discussion amongst the physicians in our hospital with our intensive care doctors and our ED doctors. We had a meeting this afternoon, and that was the number one point of discussion of, when do you think we should intubate this patient? And there's no good answer for that. I will say that you can consider, so I don't know if you guys have read, there's a lot of data out there for placing the patient in a prone position. If your patient is able to lay flat on the stretcher on their stomach with the 100% non-rebreather, there's a lot of data out. They do this with intubated patients in the ICU, but there's data out there that it actually helps patients that are not intubated. And so that is one modality you could use in transport if safe and the patient is cooperative, to try to get that oxygen level up and make the patient more comfortable. But as far as when to intubate that patient, I mean, obviously there's no, like even our intensive care doctors couldn't give us, insight as to some criteria. I mean, for me personally, if you have a patient that's clearly in distress, and in addition to that, they have, you have them on 100% non-rebreather and their oxygen level still isn't coming past 85%, they probably need to be intubated.
Right.
Yeah. And we're seeing, even amongst the emergency medicine community at large, there's a lot of debate. Everything was intubate early, we can't do CPAP. And then now another group of people are saying, well, maybe we're intubating too early. So there's a debate. I would say I agree with everything Adrian said. If you can avoid intubating them in the field, that's probably better, just especially for your own safety as well. Like, you don't want to, it's the highest risk procedure probably of the things we're doing. So, if you can get their SATs up, 88, 89, high 80s, and they're doing okay with that, and you can wait till you get to the hospital, but if they're in the mid low 80s and they look like they're struggling and you're already at a 100% non-rebreather, I think you're stuck having to intubate them.
Yeah. So, and just to add to that, so as we get more and more short events, talking about hard conversations to have, there are going to be certain patients that are, in normal times, we would intubate an 85-year-old and not think twice about it if that were their wishes. But now our doctors and providers are having to have discussions with the patient and family that says that, and we're saying, essentially, listen, your father is 85, he's got mild dementia, he's got cardiac disease, he's got diabetes, and if he craps out, we're not going to intubate him because his prognosis is extremely poor and he probably would die anyways. These are hard conversations to have, but we're going to get to the point where we have one vent and two patients, and we're going to have to make a split-second decision based on who is the candidate most likely to recover. And these are horrible things that, you know, we as emergency providers are going to have to, you may have to make that decision in the field too. But I encourage you to start thinking about, you know, you're at the scene, a 75-year-old with multiple medical problems. If you show up to the ER and the patient's intubated already, we're kind of obligated to at least continue care unless the family wants to withdraw care. But if you come in and you're not intubated, and the patient is, if we're able to make an assessment on the patient and talk to the family, that may be one less person we have to intubate. If the family says, yeah, no, I don't want to intubate, or the patient themselves says, I don't want to be on a ventilator.
Yeah. So we were discussing this earlier today, and you know, if you guys can avoid intubating them, that's the best scenario, and then let us have those hard conversations and make those choices. You know, once you intubate them, you intubated them. It's much easier to not initiate intubation and a ventilator than to try and take that away from someone. So look, sometimes you got to do it in the field. You have no other choice. But if you can get them to us, you know, with high flow oxygen and they're doing okay, that you don't have to intubate them right away, we can deal with it in the ER. But we are doing, you know, 2 physician consent with some of these patients that, you know, where we think the medical care would be futile. For example, you know, the other day we had someone brought in a 97-year-old, right, with COPD.
Uh-oh.
What happened?
We lost Jeff.
You unmuted me. The family wanted this 97-year-old with COPD, CHF, diabetes intubated, and we had a discussion. We said, look, they will never come off this ventilator. We're gonna put them in the ICU. You're not going to be able to see them, and you know, sadly, they're going to die alone sometime in the next 24 hours, you know, no matter what we do. So, you know, unfortunately, we're getting to the point where we're going to have more of those conversations, you know, as we have more critical patients coming in.
Yeah.
Could I just in case we stop? Ray was not able to sign on. I guess he had some issues, but he asked me to, through Nelson, to say, everybody should be reading their emails because that's how we're mainly communicating now, and to be mindful of your social media posts because I guess that's circulating around a little bit. So I just wanted to put that out there.
Thank you, Frank.
Okay.
So I just had one more thing to add. As I know Frank was by the ER the other day dropping off some stuff, and I happen to have this contraption that someone had donated to us. It's an intubation chamber, intubation box. And someone made it for us, and we kind of rigged it up a little bit to be a little bit more effective. Essentially, it's a box, a clear lucite box that fits over a patient's head that tries to keep or attempts to limit the amount of aerosolization. You guys can do this easily in the field if you don't have one of those. One of the things that we were using as well, dry cleaning bags. So if you have clear dry cleaning bags, maybe put some of those in your, put those in your, in the ambulance. You can lay that over your patient's, you know, head or face when intubating, and that will decrease the amount of aerosolization while you're intubating, and you could still see through it to intubate. Definitely, if you're bagging the patient, once the patient is intubated, if you're bagging the patient, then put the bag over or at least a sheet to decrease the aerosolization as well.
And Frank, I don't know if you guys have these or you can get them. The viral filters for the BVMs, they're really hard to find now because I don't think anyone has them in stock.
Yeah, we tried to get some too. We couldn't get any.
I thought Adrian had some.
No, I'm sorry. We do have a few. We just don't have a large amount.
Yeah. And the other thing I will say is just a reminder that, you know, you want your intubation, you want first pass success and as quickly as possible. So it's a good time to make sure you're really sharp with your intubation skills.
Yeah. It's actually, I've read some stuff that says if you can't intubate or if it's a difficult intubation, then use a supraglottic airway. Yeah. It's better than multiple attempts.
Yeah, that's a good point. I would say also, like, if the patient's unresponsive and they'll tolerate supraglottic airway, I personally have no issue with you guys going to a supraglottic airway right away.
Frank, or Dr. Rich, with is there any sort of like news on us getting ketamine, and would that be better, for intubating the patients versus like using etomidate?
No, what would be better would be paralytics, but ketamine or etomidate is going to still give you the same level of, sedation, so to speak. Neither one of them are a muscle relaxer, so I don't think ketamine is going to help you that much over etomidate in that situation. Plus, I think with everything that's going on right now, it'd be hard to operationalize that in the middle of this.
Yeah, I don't think right away we're going to be able to put that out in time.
Yeah.
Okay, does anybody have any questions? Ray is texting me, so if you have any questions for Ray, I'm texting back and forth with him. Does anybody have anything, or is there anything we could be doing better operationally? I mean, I think everybody knows that, Bo Nelson and myself are on 4 to 12s and weekends. So there's, Monday through Friday daytime. Ray and Tim are here. I've been coming in a little bit in the daytime myself too. And 4 to 12s were here. I've been texting all the stations, at the start of the shift to ask them if they need anything. And if they do need anything, we're running it out. Angel has been phenomenal with getting equipment out. So, please feel free. If there's anything you ever need, we'll get it out to you immediately. We're going to start using the BERT technicians now to shuttle equipment around during the daytime while they're working, and early evening. I think they're on until midnight. Fit testing is going on. You're going to be getting an email soon telling you the times that fit testing is available at headquarters. We trained all the BERT technicians to do fit testing, so fit testing will continue and go on. We are getting supplies on a limited basis from the county. So right now our PPA stock is still very good. And, obviously please use it. And other than that, I mean, we're plugging away doing the best we can. So if you have any suggestions, please email Bo and myself and we'll, get back to you. But
and same for us. I know things change rapidly and you may be hearing things out there that may be true, may not be true. Frank can get a hold of us at any time if you need more information from us or have questions. You don't have to wait for one of these calls.
Yep.
And Ray just texted me, we are going to do this once a week. We'll have some, I mean, it doesn't have to be we'll still try to do the medical control one separate, but I think he wants to have like an operational one if anybody has any questions or concerns and stuff like that. So we'll definitely be using this, and judging from the amount of people, I think we're up to 33 people now. It seems like it's probably better than we ever had at staff meetings.
Yeah, this is terrific, actually.
The other thing to bring up is we're going to have to do this for the Cardizem. That's going to be a change because of the issue.
Yes. Oh, all right. Yeah, we're having it right. So Bo's alluding to the fact that the way we carry Cardizem, where we were putting it out there for 30 days because we weren't refrigerating it, that option is no longer available for us. So there's a method now where we'll be reconstituting it, and it has a much longer shelf life, obviously, before it's reconstituted. So that's the system we're going to be going to coming forward. So there'll be, information coming out, a video to watch on how to do it. But if you've ever reconstituted anything before, it's, pretty much the same technique. It's going to run in as an infusion, but we'll put that all out as soon as we, well, it'll have to be by the end of the month because we're running out. So. Okay. Anything else?
Thank you so much.
Okay, so please use your PPE, stay safe, and thank you for doing what you're doing. And don't think that anybody's being judged. I understand these are totally impossible patient care encounters, but I just, as much as we could do to minimize your risk, and stuff, because I know the state put out documents, but it doesn't stop anybody from being sued just by the fact that state put out these documents. So the best you can to, keep medical control in the loop and everything like that would be helpful to alleviate.
A lot of these are difficult decisions and things, honestly, we never thought you'd have to face ever. So please call medical control. That's the thing I want to leave you with. If you don't take this all on yourself. If you have concerns, questions, not sure what to do, call us.
Absolutely.
And just realize too, but we also know you guys are like overwhelmed in the ER.
Yeah, but we get that, but we're there for you guys.
Yeah, I mean, you guys are part of the team. I mean, if
you're in the middle of an intubation, we're going to call you and you're going to be like, oh, well, I'm kind of busy right now. What do we do next?
Well, listen,
that's true.
There's more than one of us, and it's not a perfect world, but
right.
we will definitely take your call.
Not a perfect world out here in the world too, where we're working.
And if you're calling one hospital and you can't get someone, you can call the other hospital, right? I mean, even if that's where the
we know
patient
each
wanted to
other's
go.
phone numbers. We can give a report for you to the other hospital.
Yeah.
Yeah, what's the other hospital? Press number 2, right? On the medical control.
Yeah.
I think you have multiple choices. You could even bother Westchester.
Yeah.
So.
Thanks for what you're doing, guys. Thanks a lot.
Okay.
Thank you, guys. Everyone stay
Everybody,
safe.
everybody, please stay safe. And like Frank said, if you need something, don't hesitate to get in touch with us. We'll do the best we can.
Yep.
Okay.
All right, guys.
Everybody have a good night.
Thank you.
Take care.
Thanks.
Thank you.
Bye-bye.
Bye.